Good afternoon, everyone. So I believe that I'm introducing the afternoon session. I've entitled this Cancer and COVID-19 Pneumonia and Pneumonitis, June 2020, and we're doing biomarkers, treatments, and a path forwards. And I thought that during this presentation that I would try to bring together themes of cancer, checkpoint inhibitors, COVID-19, touch on cancer pneumonitis, the juncture of checkpoint inhibitors with COVID-19, touch on CAR-T, IL-6, key biomarkers, and treatment approaches. So since we're after lunch, I thought I'd start with something visual. This is my past battle over the past 30 years. This is Her2 disease, showing the amplification of multiple receptors on the cell surface, which is what is driving the patient's tumor, and which is what we tackle. And then in the next one is COVID-19, which is somewhat different. On the left, we actually see the spike protein of SARS-CoV-2. You've got the S1 section in green. You have the S2 section in blue. And then this is actually the variant which is most common in New York and in Italy. And the Scripps researchers have recently found that a mutation has occurred straight at that junction of the blue and the green. That is relatively unstable in the original, but the new mutation is far more stable in structure and can infect more cells. So that's the latest New York and Italy virus. And then you see basically the bottom of that virus tickling into the cell in multiple points. So first of all, what I've been dealing with for 50 years, pneumonitis in cancer, inflammation of the lung, absent infection. Pneumonia is inflammation caused by infection. From non-oncology agents, it can come from a toxin or allergen. For oncology agents, it's usually caused by radiation. Some of the agents I worked with 50 years ago, cyclophosphamide, methotrexate, topicide, and now you see it in several of the targeted cancer drugs and immunotherapies. And it's commonly treated with corticosteroids, oxygen therapy, and bronchodilators. So on all of these, you'll see that I've highlighted stuff in red. I've left the slides intact because you can access them afterwards. So this is a meta-analysis of 11 clinical trials looking at pneumonitis, which is caused by checkpoint inhibitors. Relatively uncommon, odds ratio of all grade pneumonitis over non-checkpoint inhibitor was 3.96 and 2.87 for high grade. So you basically have a 3% incidence of high-grade pneumonitis. If you use a double, if you use Nivo and Ipi versus Ipi alone, again, for high-grade pneumonitis, your risk odds ratio has 1.86. And of interest, there's no real difference between lung cancer patients and the other cancer patients. So this is looking for a beautiful presentation from Melissa Bersinelli, who I think is in Parma. So she shows this potential overlap of COVID-19 and checkpoint inhibitor pulmonary toxicity. There are two ways of getting this. One is an organizing pneumonia, but the other is an inhibitor-related pneumonitis. And of course, she gives a warning about treating with immune checkpoint inhibitors while in the initial stages of COVID-19. On this slide, this goes into mechanism. Immune hyperactivation, represented by cytokine release syndrome, occurs in the setting of T-cell engaging immunotherapy. So we've got this whole concept of cytokine release. One of the most important mechanisms underlying patient deterioration is cytokine storm, which we've heard a lot about in the press over the past few months. And this can lead to acute respiratory distress syndrome, and multiple organ failure. And that's what our organizer, Bill Workmeister, asked me to address. So you have hyperactivation, CD4, CD8 T cells, increased concentrations of highly pro-inflammatory factors in CD4 T cells, and high concentrations of cytotoxic granules in CD8 T cells. Overactivation of T cells tends to contribute to the severe immune injury in the disease. So just touching on CAR-T incredibly quickly, and I'm going to use this as an introduction into IL-6. So you have in CAR-T therapy, where you have immune activation in the form of cytokine release, your key levels of increasing cytokines are IL-6, IL-10, interferon gamma, and GM-CSF. And this introduces the concept of the IL-6 inhibitors with a word which I can never say, it's tocilizumab. So you may wonder what on earth this is. This is Castleman syndrome. This affects 5,000 individuals in the US, and this is actually the tattoo of Castleman on one of the patient's shoulders. And this is the wonderful David, again I have a problem, Fajgenbaum, who is a doctor himself, and this shows him in full form at Georgetown playing football and after contracting the disease. So why am I diverting on Castleman's? So this is David now, you'll be pleased to see. He's in fine fickle. This is multicentric Castleman disease, and it's associated again with herpes virus type 8, HAV8, and human immunodeficiency virus, HIV. And what is the key driver? Again, we come down to IL-6. So the list at the bottom are potential treatments, not just for this disease, but anything driven by IL-6, which includes COVID-19. So we have rituximab, we have siltuximab, we have docilizumab, which was the drug referred to in the last slide. We have bortezomib, selective proteasome inhibitor, and then we have Ilancara, which is the interleukin-1 receptor agonist. So I show this slide, even though it's incredibly detailed and one patient, but it shows the power of the removal of IL-6. So the germinal centers of hyperplastic lymph nodes of Castleman's produce large quantities of IL-6 without any significant production of other cytokines. So in a patient with a solitary hyperplastic lymph node, clinical improvement and decrease in serum IL-6 was simply observed following one surgical removal of the involved lymph node. And there was a correlation between serum IL-6 level, lymph node hyperplasia, hypergammaglobulinemia, increased level of acute phase proteins, and clinical abnormalities, which gives us great hope that if we can suppress IL-6 effectively in COVID-19, we're going to move away from ARDS and these basically symptoms of cytokine release. So that gives us the promise of if IL-6 is taken away. So this is the reference for role of cytokines, including interleukin-6 in COVID-induced pneumonia, macrophage activation syndrome-like disease. This is the reference which you will have, and you have non-survival in ARDS was linked to sustained IL-6 and IL-1 elevation. So this is Genentech's drug. They've run a trial in Paris in the university system, including 129 hospitalized patients. This is tocilizumab, and it's designed to mitigate the body's natural immune response. And during the trial, the drug was able to significantly decrease the number of deaths or life support interventions when compared to a control group. So this is looking at the cytokine storm syndrome. Again, you will have this afterwards, but what you see in this is indeed a primary cascade of cytokines heading up to a secondary cascade. And if you look at the little arrows going along, you'll see the typical culprits. Type 1, type 3, you'll see the type 1 and IL-1 beta. You've got the IL-33, the IL-6, IL-10, AREG, then you've got interferon gamma coming in there, and TNF alpha at the bottom. It's a lovely visual picture of the cytokine storm. So this breaks it down into 3 phases. You have phase 1, which is the infection of epithelial cells, which is going into great detail on this. And then you have the immune cell activation and acute inflammation. And if you watch the way I'm just going to end this talk soon, it's all to do with immune cells, interleukins, and acute inflammation. And then on the left, you have a stop where your patient gets better. And on the right, you have the go, where you have the cytokine storm, the neutrophilia, monocytopenia, and this is severe COVID-19. So these are the published COVID-19 biomarkers. This was published by my colleagues who assembled this. This is my little red highlighted list, according to my personal choice. And I have bolded the IL-6 there, but you see the IL-1 beta, you see the IL-10 and 12, IL-22 binding protein, you see C-reactive protein, which is measured in virtually all of the trials, together with ferritin, which is measured in all of the trials, and then we've got TNF alpha at the bottom. This is my colleague Ralph's parchment list of the drug that we are working on, which will be the subject of the next presentation. This is Fenretinide, decreasing inflammation, reducing the levels of key cytokines, reducing the levels of related mediators of inflammation, and on the right is the complete list of what Ralph has identified as his key markers, which almost replicate mine. So this is my summary of Fenretinide. I believe the anti-inflammatory effect is dominant, but there is an antiviral effect, which has been shown in cell culture in the Utah labs. In fact, this acts against a series of 7 different viruses. And so this is the proposed mechanism of action. I would focus you right in the center. You have the immune response, you have the cytokine storm, you have the tissue inflammation, and then you have the clinical results at the end of that. So you have all the down modulation of the interleukins in the second column down, and then you have the antioxidant activity of the beta-carotenoids in the third column. So these are the mitigation of the inflammation mediators. You'll see that these all have references on them. You will have this slide available, but it's got IL-1 beta, 6, 10, 12, the 22 binding protein, TNF alpha, and of course IL-8. So this is my last slide. This is the path forwards. I look upon remdesivir, I'm sorry, there's a typo in there, as the antiviral base. Fenretinide will suppress the inflammation and the immune activation. So it's basically a natural partner to remdesivir, and indeed it does have its own antiviral activity as well. And then depending on where we are at the beginning of next year, we will propose to add a third agent into this. If you look on the next slide, which I'm not going to show, we show all the abbreviations. We also have some references on there. And I will now let my key partner, Earl Holzapfel, address you on the development of the Cytec compound. I thank you so much.